Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 269 of our pharmacotherapy series, which majors in tuberculosis. The first question reads, STE, a 65-year-old woman, was placed on isoniazid 300 mg per day, rifampin 600 mg per day, pyrazinamide 1,500 mg per day, and ethambutol 1,200 mg per day for initial treatment of active pulmonary TB. 2 months after the initiation of therapy, she began to complain of blurred vision. A routine eye examination and visual field tests yielded a diagnosis of optic neuritis. No evidence was seen of glaucoma, cataracts, or retinal damage. Laboratory tests were within normal limits except for an elevated serum uric acid, that is 9.7 mg per deciliter, and a slightly elevated serum creatinine, that is 1.6 mg per deciliter. No symptoms of joint pain were associated with the elevated serum uric acid, and there was no history of gout. Her estimated creatinine clearance based on her weight of 65 kg was 36 ml per minute. Could the visual problem and increased uric acid levels be related to her medications? STE's decrease in visual acuity is compatible with ethambutol-induced optic neuritis. This condition is characterized by central scotomas, loss of red-green color vision, or less commonly, a peripheral vision defect. The intensity of these ocular effects is related to the duration of continued therapy after decreased visual acuity is first noted. Optic neuritis is related to both dose and duration, and it rarely occurs at doses of 15 mg per kilogram. The incidence is estimated to be 6% for doses of 25 mg per kilogram and increases to 15% for doses in excess of 35 mg per kilogram. Recovery, which may take months, is usually, but not always, complete when the drug is discontinued. Optic neuritis manifested in STE is probably caused by the use of an increased ethambutol dose, that is, 18.5 mg per kilogram, in a patient with impaired renal function. Because ethambutol adds no additional benefit to isoniazid and rifampin after the first 2 months for susceptible organisms, it can be discontinued. Ethambutol is excreted by the kidney 50% to 80%, and her ethambutol dosing interval should have been increased based on the decline in creatinine clearance. Her visual acuity should be monitored closely through periodic eye examinations, and she should be instructed to contact her physician immediately if she experiences any further visual changes. STE's elevated serum uric acid also may be attributed to her ethambutol as well as a decline in her renal function, but it is more likely caused by pyrazinamide, which decreases the tubular secretion of urate. Asymptomatic hyperuricemia secondary to drugs usually does not require treatment. The next question reads, GPH, a 75-year-old, 80-kilogram man who resides in a nursing home, becomes disoriented, refuses to eat, and has a productive cough. Physical examination reveals a thin man with slight difficulty breathing. Laboratory findings are essentially normal with the exception of a slightly elevated blood urea nitrogen of 25 mg per deciliter and serum creatinine of 1.3 mg per deciliter. Chest radiography reveals infiltrates in the right lower lobe. He has a history of congestive heart failure, which is well controlled. Blood, urine, and sputum samples are sent for culture and susceptibility testing. The initial gram stain is negative. Because the nursing home has recently had 2 cases of active TB, a PPD skin test and sputum smear for AFB are ordered. The PPD skin test in duration is 16 mm, and the sputum smear is positive for AFB. GPH's admission skin test several months ago was negative. Discuss the presentation of TB in the elderly, and the appropriate treatment of active disease in GPH. Is the incidence of drug side effects higher in the elderly? Should other patients in close contact with GPH receive isoniazid therapy? In 2014, the overall case rate of TB in adults 64 years or older was higher than all other age groups, 4.8 per 100,000 population. Similar to other age groups, the case rate for persons 64 years or older has declined every year since 1993, when the case rate was 17.7 per 100,000 population. In 2014, 2.2% of TB cases were reported in residents of long-term care facilities, and the case rate for nursing home residents is 1.8 times higher than that for elderly persons living in the community. Active TB disease in the elderly has been attributed to decreased immune function followed by reactivation of an earlier infection, but active disease is a common, endemic infection in nursing home patients with no previous immunity negative skin test to Mycobacterium tuberculosis. The incidence of positive tuberculin skin tests increases after patients have been in the nursing home longer than 1 month. Therefore, all patients entering a nursing home should be tested with 5 Tu of PPD. If the initial test is negative and a source case is present in the nursing home, as illustrated by this case, this test should be repeated in 1 month. The rate of tuberculin skin test conversion from negative to positive tests in this population is approximately 5%. If these recent converters are not treated with isoniazid, approximately 17% will develop progressive pulmonary TB. Regarding diagnosis of active TB in elderly patients is difficult because classic symptoms of cough, fever, night sweats, and weight loss are often absent, and elderly patients may describe their symptoms poorly. The chest radiograph and PPD skin test may be the only signs of TB infection. Frequently, the chest radiograph is atypical, resembling pneumonia or worsening heart failure. Chest radiographs in the elderly are less likely to reveal upper lobe infiltration, however, more commonly they will show extensive infiltration of both lungs. If the patient's clinical disease is caused by reactivation, the chest radiograph often shows apical infiltrates or nodules. If the disease is progressing from an initial infection, as in the case of GPH, lower lobe infiltrates may be present. TB in this population may present clinically with changes in activities of daily living, chronic fatigue, cognitive impairment, anorexia, or unexplained low-grade fever. Nonspecific signs and symptoms that range in severity from subacute to chronic and that persist for weeks to months must alert clinicians to the possibility that unrecognized TB is present. Sputum examination for Mycobacterium tuberculosis, and AFB smear and culture should be performed in all patients, including the elderly. Let's now talk about treatment of active disease in the elderly. The principles of TB treatment are the same for the elderly as for any other age group. Because GPH has clinical symptoms of a respiratory infection, positive sputum smears for AFB, and a positive tuberculin skin test, he should be treated with a 4-drug regimen for active TB disease. Most TB cases in elderly patients are caused by drug-susceptible strains of Mycobacterium tuberculosis. However, notable exceptions would be older patients who are from a country or region where the prevalence of drug-resistant strains is high, persons who have been inadequately treated in the past, or persons who acquired the infection from a recent contact known to be infected with drug-resistant Mycobacterium tuberculosis. GPH's drug regimen should include isoniazid 300 mg, rifampin 600 mg, pyrazinamide 2000 mg, and ethambutol 1600 mg daily for 8 weeks, followed by isoniazid and rifampin daily or 2 to 3 times a week for 16 weeks, using DOT. Another option might be isoniazid, rifampin, pyrazinamide, and ethambutol daily for 2 weeks, followed by twice weekly for 6 weeks, then isoniazid and rifampin twice weekly for 16 weeks. Some clinicians prefer treating the elderly with 9-month regimens of isoniazid and rifampin. GPH should also receive pyridoxine 10 to 50 mg with each dose. Regarding adverse drug effects, although isoniazid hepatitis is more common in elderly patients, both isoniazid and rifampin are generally well tolerated within this age group, with major hematologic or hepatic side effects occurring in 3% to 4% of patients. Therefore, serum aminotransferases should be assessed at baseline, and GPH should be observed monthly for clinical signs of hepatitis. As discussed earlier, routine monitoring of LFTs remains controversial because transient, asymptomatic elevations do occur among the elderly. Although uncommon at 600 mg, rifampin given twice weekly may cause a greater incidence of flu-like symptoms. Because potential drug interactions with isoniazid and rifampin are possible, any medication added to the patient's regimen should be carefully evaluated. Considering that GPH has age-related decreased renal function, signs of ethambutol-induced visual dysfunction should be monitored carefully. We will now discuss treatment of latent infection in the elderly. Treatment of elderly patients with positive tuberculin skin tests but no active TB disease with isoniazid 300 mg daily for 6 to 9 months is essential if a source case is present in the nursing home. Stead and colleagues reported only 1 case of active disease in patients receiving therapy for latent TB infection compared with 69 cases in untreated patients. In patients with recently converted skin tests, 1 patient in the group receiving isoniazid therapy had active disease compared with 45 who received no treatment. Daily rifampin for 4 months or weekly isoniazid plus rifapentine for 12 weeks are also acceptable regimens in the elderly. The next question reads, SMS, an ill-appearing 29-year-old Asian man, is admitted to the hospital with signs and symptoms of pneumonia. He is coughing, and his chest radiograph indicates bilateral infiltrates. He is placed in respiratory isolation pending the results of sputum testing for Mycobacterium tuberculosis. He states that he was diagnosed with TB approximately 3 months ago, and treatment was initiated with isoniazid, rifampin, pyrazinamide, and ethambutol. However, he stopped taking his medication after 1 month. An HIV test was performed 3 months ago, which was negative. What is the likelihood of acquired drug resistance in Mycobacterium tuberculosis? In the United States, isoniazid resistance was 18.9% and resistance to both isoniazid and rifampin was 7.1% in patients with previous TB in 2014. Resistance in Mycobacterium tuberculosis is either primary or acquired. Primary drug resistance occurs when a patient harbors a resistant strain before any drugs have been administered. Acquired drug resistance occurs when resistant subpopulations are selected as a result of treatment errors, such as addition of a single drug to a failing regimen, inadequate primary regimen, failure to recognize resistance, and, most importantly, non-adherence to the prescribed regimen. Sporadic ingestion, inadequate dosages, or malabsorption of medications can cause susceptible Mycobacterium tuberculosis strains to become resistant to multiple drugs within a few months. These resistant organisms can then be transmitted to persons who have never received treatment and lead to primary resistance in those patients. SMS is a foreign-born person of Asian ethnicity and may have primary resistance from his country of origin, making a detailed exposure history essential for the treatment of his infection. SMS is also an example of the problem of treatment failure caused by non-adherence and the potential development of drug-resistant organisms. Homelessness and lack of awareness of the severity of TB have been shown to be significantly associated with interruptions in TB therapy. Therefore, educational efforts to improve a patient's understanding of TB disease are critical for appropriate treatment of the disease. Many factors can affect the outcome of therapy for Mdrtb, including HIV status, treatment adherence, the number of drugs to which the tubercle bacilli remains susceptible, and the time since the first diagnosis of TB. In one study, all 11 patients who were HIV positive died during observation. In another study, 77% of patients with Mdrtb had sputum cultures convert to negative in a median time of 60 days, ranging from 4 to 462 days, but 23% of patients never converted to negative cultures. Of the patients who converted, 60% converted after 4 months of therapy. Predictors of a longer time for sputum culture conversion were high initial sputum colony counts, bilateral cavitation on chest radiograph, previous treatment of Mdrtb, and the number of drugs the initial isolate was resistant to at the beginning of therapy. The next question reads, can SMS be cured by drug therapy, and if so, how should he be treated? Because his recent HIV test was negative, SMS has a higher probability of treatment success. In HIV-negative patients, 32, that is 97%, of 33 patients with Mdrtb were cured, and these patients received an average of 5 second-line drugs. Only one relapse occurred 5 years after treatment. Therefore, SMS's current regimen should be re-evaluated, drug susceptibility testing should be determined, and the patient should be referred to a specialist or consultation at a specialized treatment center. Molecular drug resistance testing should be performed to evaluate resistance to rifampin, which is a reliable surrogate for Mdrtb. Standard susceptibility testing methods should be performed for the other agents, although results may not be available for several weeks. If the rapid molecular test detects the presence of mutations to rifampin, the patient should then begin therapy for Mdrtb. However, there is no standard treatment regimen for Mdrtb. When revising a treatment regimen, at least 3 previously unused drugs to which the organism is susceptible should be used, and one of these agents should be injectable. A new regimen should contain at least 4 drugs, possibly more, depending on disease severity and resistance pattern. Treatment should be given by DOT, and the recommended duration is 18 to 24 months. However, only 40% of patients with Mdrtb complete a full 18 to 24 months of therapy. The efficacy of a standardized treatment regimen for a shorter duration of therapy was evaluated in patients with documented Mdrtb. The study population consisted of 427 patients with a mean age of 34 years. 81.5% had bilateral disease on chest radiograph, and patients had exhibited TB for approximately 30 months on average. The mean body mass index was 16.1 kg per meter squared, indicating severe emaciation. The intensive phase consisted of 3 or more months of therapy with 6 to 7 agents, and doses were based on body weight. Daily ofloxacin and gatafloxacin doses were 400, 600, and 800 mg for body weights less than 33 kg, 33 to 50 kg, and greater than 50 kg, respectively. The most effective treatment regimen required a minimum of 9 months of therapy with gatafloxacin, clofazimine, ethambutol, and pyrazinamide throughout the treatment period, with the addition of high-dose isoniazid, prothionamide, and kanamycin for a minimum of 4 months during the intensive phase. Among 206 patients receiving this regimen, the relapse-free cure rate was 87.9%. The most common adverse events with this regimen were vomiting, that is 21.4%, diminished hearing acuity, that is 6.3%, dysglycemia, that is 3.9%, and ataxia, that is 3.9%. These results suggest that it may be possible to adequately treat patients with Mdrtb with shorter courses of therapy. However, prothionamide and kanamycin are unavailable in the United States. Fluoroquinolones are active against mycobacteria, including Mycobacterium tuberculosis, and they penetrate rapidly into macrophages and exhibit intracellular mycobactericidal activity. Fluoroquinolones inhibit DNA gyrase in Mycobacterium tuberculosis, but the other molecular target of these agents, topoisomerase 4, is absent. Ciprofloxacin, ofloxacin, and levofloxacin have been used long-term for the treatment of mycobacterial infections and were well tolerated with few serious adverse effects. Limited data suggest that moxifloxacin is an acceptable option in the treatment of Mdrtb. Selection of fluoroquinolone resistance has been observed in vivo, and complete cross-resistance within the class is the accepted rule. Other second-line medications used for Mdrtb include p-aminosalicylic acid, cycloserine, ethionamide, and capreomycin. These agents are associated with numerous side effects and should not be prescribed without the guidance of an expert in the treatment of Mdrtb. Bedaquiline was FDA approved in late 2012 as part of combination therapy with at least 3 or 4 other drugs in adults with pulmonary Mdrtb when other alternatives are not available. Bedaquiline is a novel drug that inhibits mycobacterial adenosine 5-triphosphate synthase, thereby inhibiting energy production in Mycobacterium tuberculosis. The drug is available in 100 mg tablets, and the recommended dosage is 400 mg daily for 2 weeks followed by 200 mg thrice weekly for 22 weeks. Bioavailability of bedaquiline is increased twofold when administered with food, and each dose should be administered by DOT. Bedaquiline is metabolized by CYP3A4, and it is recommended to avoid concomitant administration of bedaquiline with moderate CYP3A4 inducers e.g. efavirenz, and strong CYP3A4 inducers e.g. rifamycins. Strong CYP3A4 inhibitors may increase systemic exposure and adverse events of bedaquiline, and use of strong CYP3A4 inhibitors for more than 14 consecutive days should be avoided while the patient is receiving bedaquiline. Bedaquiline can cause QT prolongation, and additive prolongation may occur with other drugs known to prolong the QT interval. Bedaquiline received accelerated FDA approval based on the surrogate marker of time to sputum culture conversion in Phase 2 studies. In the first study, 47 patients with Mdrtb received bedaquiline or placebo added to a preferred background regimen of kanamycin, ofloxacin, ethionamide, pyrazinamide, and cycloserine or taururzidone for 8 weeks. After 8 weeks, the background regimen was continued for a total of 96 weeks. Time to sputum culture conversion was significantly reduced in the bedaquiline group, and sputum cultures were negative in 48% of patients in the bedaquiline group compared to 9% in the placebo group at 8 weeks. After 24 weeks, 81% of patients in the bedaquiline group had negative sputum cultures compared to 65.2% in the placebo group. However, after 104 weeks, treatment success was achieved in 52.4% and 47.8% of patients in the bedaquiline and placebo groups, respectively. In the second study, 160 patients with pulmonary Mdrtb received either placebo or bedaquiline 400 mg daily for 2 weeks followed by 200 mg thrice weekly for 22 weeks with the same background regimen described previously. After 24 weeks, patients continued the background regimen for a total of 18 to 24 months. The median time to sputum culture conversion was 83 days in the bedaquiline group compared to 125 days in the placebo group, with a p-value less than 0.001. Compared to placebo, significantly more patients in the bedaquiline group had negative cultures at 24 weeks, 79% versus 62%, with a p-value equal to 0.008, and at 120 weeks, 62% versus 44%, with a p-value equal to 0.04. However, mortality was significantly higher in patients receiving bedaquiline, 13% versus 2%, with a p-value equal to 0.02. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 270.